to thank the organizers of this symposium for the invitation to speak to you about risk reduction of breast cancer risk in high-risk women. I serve as the Director of Breast Medical Oncology and Research in the Geisinger Health System in central Pennsylvania, and have spent my career looking at methods to reduce breast cancer risk. First of all, we can define chemoprevention as the use of natural or synthetic chemical agents to reverse, suppress, or prevent carcinogenic progression to invasive cancer. And over the last 30 years or so, a number of compounds, particularly the selective estrogen receptor modulators, or the SERMs, prototypically represented by tamoxifen, but also by the benzothiophene raloxifene, and others shown on this slide, along with the aromatase inhibitors, exemestane and anastrozole, shown at the bottom of the slide. And all of these compounds have been shown in prospective randomized placebo-controlled trials to reduce the incidence of breast cancer in women at increased risk. And this is made possible by the fact that breast cancer, as I often explain to patients, is not like an accident in an intersection where two vehicles collide, but is a process. And it occurs in breast tissue by a progression from normal duct epithelium to hyperplasia, onto atypia and in situ cancer, and eventually invasive ductal and lobular carcinoma. And this process, we now know, can be interrupted by the use of SERM medications, as well as the aromatase inhibitors. And the first task in reducing breast cancer risk is to identify those subjects who are at increased risk. The US National Cancer Institute in the 1980s and early 1990s looked at data from a large breast cancer screening project called the Breast Cancer Detection and Demonstration Project. And from those women who were followed prospectively for decades, they identified these 7 risk factors shown on this slide. And by using just these 7 risk factors, the risk of developing breast cancer over the next 5 years can be very accurately determined. And that was shown in this study from the National Surgical Adjuvant Breast and Bowel Project, the NSABP, who conducted the breast cancer prevention trial, which we'll talk about in a moment. And that trial contained a placebo group, and they had their breast cancer risk ascertained at clinical trial enrollment, and then were followed prospectively for 7 years. And as you can see on this slide, regardless of the age of the patient, whether they were premenopausal and 49 or less, whether they were perimenopausal, 50 to 59 years, or whether they were older, middle-aged women who were 60 years or older, the expected to observed ratio of cancers observed in the placebo arm of this randomized prospective trial was 1, meaning that the model accurately predicted the incidence of breast cancer over time. And this is the NCI breast cancer prediction tool, risk assessment tool, or sometimes referred to as the Gale model from its originator, Mitchell Gale. There are also other models, such as the Tyrer-Cuzick model, which is widely used in the United Kingdom. But these quantitative models allow assessment of risk and identification of women at increased risk. Now, this cartoon slide shows how estrogen interacts with the estrogen receptor, and a estrogen ligand bound to receptor dimerizes with another ligand receptor complex and has activation functions on the dimerized molecule, which then binds to the estrogen response element, the ERE shown on this slide, and recruits co-activators that lead to activation of RNA polymerase transcription and cellular proliferation. that process can be interrupted by SERMs, selective estrogen receptor modulators, such as tamoxifen, that bind to the receptor, and the dimerization still occurs, but activation functions are not fully activated. And when the dimerized receptor ligand complex binds to the estrogen response element, RNA polymerase is not activated and transcription does not occur, reducing cellular proliferation and, as we will show, the incidence of invasive cancer. So the first prospective randomized trial that I alluded to a moment ago was conducted by the National Surgical Adjuvant Breast and Bowel Project, a National Cancer Institute funded cooperative group that launched this trial in the mid-1990s and recruited over 13,000 women who were randomly assigned to either tamoxifen 20 milligrams a day or placebo. All the women were 35 years of age or older, had not had a history of invasive breast cancer or other malignancy, and were randomly assigned to the tamoxifen or placebo. And as shown on this slide, after 5 years of follow-up, there was a markedly statistically significant reduction in the incidence of invasive breast cancer among women taking tamoxifen compared to those taking placebo. And this represented a 49% in the risk of invasive breast cancer. These results were then updated with 7-year follow-up. Patients stopped taking tamoxifen or placebo at 5 years. And it's instructive to note that after cessation of tamoxifen at 5 years, with continued follow-up for an additional 2 years, the risk reduction persisted and was statistically significant for both invasive cancer incidence and non-invasive breast cancer incidence. We also know that there are microanatomical features in the breast, particularly atypical hyperplasia, either in the lobules or in the ducts. And this phenomenon has been exhaustively studied and reported by Lynn Hartman at the Mayo Clinic. And she used 2 large cohorts followed over 3 decades at both the Mayo Clinic and the Vanderbilt University in Nashville. And like we saw in the breast cancer prevention trial, there was a profound effect of tamoxifen on the incidence of lobular carcinoma. And even though it was not statistically significant, it was still markedly reduced among tamoxifen takers. And with atypical hyperplasia and tamoxifen use, the incidence of invasive cancer was reduced by 85%. So now returning to Dr. Hartman's data, what she showed over 25 years of observation was that if you have atypical hyperplasia, the incidence of invasive cancer is increased to the same order of magnitude that we see in mutation carriers, such as women with mutated BRCA1 or BRCA2 tumors. And that incidence is dependent on the number of foci seen in breast biopsy with atypia. And if you have 3 or more foci of atypia on a breast biopsy at baseline, at 25 years, the risk of invasive cancer approaches 50%. And as I said, the incidence in BRCA1 and 2 mutation carriers is about 1 to 2% per year, which is as high as women with atypia. So women with atypical hyperplasia, either lobular or ductal, constitute a high-risk group, as do those with increased quantitative risk assessment. Well, following the publication and identification of the benefits of tamoxifen in the breast cancer prevention trial, our group, the NSABP, initiated the study of tamoxifen and raloxifene, or the STAR trial, in the mid to late 1990s. And this trial enrolled 19,000 women, all postmenopausal, because raloxifene had not been studied in premenopausal women. Raloxifene was developed as treatment and prevention for osteoporosis and osteoporotic fractures. And it was observed in the osteoporosis trials that raloxifene not only reduced fractures and prevented the progression of osteoporosis, it also reduced breast cancer incidence. So those observational and some controlled trials for osteoporosis led to the design of the STAR trial. And because the breast cancer prevention trial had shown such a dramatic effect with tamoxifen, it was thought unethical to include a placebo group in this trial. So this was restricted to postmenopausal women because of the absence of data for raloxifene in premenopausal women. Those women were stratified by their age, by their Gale model quantitative risk, by race, and whether or not they had a history of lobular carcinoma in situ. And then they were randomly assigned with about 9,700 women in each of two groups to either receive tamoxifen daily or raloxifene daily for 5 years. And what was shown was that both agents caused a dramatic reduction in the incidence of breast cancer, invasive cancer, and the predicted cases, since there was no placebo group, the predicted cases were estimated using the validated Gale model. So we are confident that those predicted number of cases were accurate, and the reduction with tamoxifen compared to the predicted number of cases was nearly 52%, and the reduction with raloxifene of the incidence of invasive breast cancer was about 40%. And we also know that tamoxifen leads to an increased risk of invasive endometrial carcinomas. That risk, as shown here, is about 2 per 1,000 women years, or about 1% of all postmenopausal women who take tamoxifen for 5 years. 1% will develop invasive endometrial carcinoma. 45% fewer cases were seen in raloxifene, and in the placebo-controlled osteoporosis trials, this incidence of just about 1 per 1,000 woman years is equal to the placebo risk. So raloxifene does not increase the risk of endometrial cancers the way tamoxifen does, as demonstrated in this trial, the STAR trial, and in the placebo-controlled osteoporosis trials with raloxifene. We also learned that women who came forth for risk evaluation for the STAR trial, only half of them were eligible. And of all the eligible women, only 20%, that 19,000 or so, agreed to randomization and enrollment in the trial. But if you were a woman with a diagnosis of atypical lobular or ductal hyperplasia, they were 70% more likely to agree to take SERM therapy. And we believe this is related to the fact that these women were told they had a histologic abnormality on a prior breast biopsy that increased their risk. And they also were shown risk-benefit profiles that when they had atypia, the benefit, as we've seen with tamoxifen therapy, was large, and the risks were very small. Now, after the publication of the STAR trial in 2006 and its update again in 2010, Gabe Hortobagi and Pal Brown wrote this editorial in Cancer Prevention Research, comparing the risks and benefits from both tamoxifen and raloxifene as demonstrated in the STAR trial over a 7-year observation period. And the green bars, the vertical green bars in this slide, show the large benefit in terms of the invasive and non-invasive breast cancers that were prevented by either tamoxifen on the left or raloxifene in the middle, compared to the endometrial cancers and thromboembolic events that occurred with either SERM, shown by the blue small bars below the x-axis. So overall, there was a large net benefit of using either SERM for the reduction of breast cancer risk. There were also other trials published through the mid to late 1990s and early 2000s using tamoxifen, raloxifene, another SERM, lasofoxifene, and the aromatase inhibitor exemestane. Not shown in this slide. There was also a trial called IBIS-2, the International Breast Cancer Intervention Study. IBIS-2 was conducted in the United Kingdom and used the aromatase inhibitor anastrozole, and also all of these trials showed a marked reduction in breast cancer incidence, either with SERMs or with the aromatase inhibitors. And these data were summarized by Jack Cusick initially in 2003 and then updated 8 years later in 2011. And the meta-analysis showed about a 38 or 39% reduction when you combine all of the data from all of these trials with the aromatase inhibitors, showing a large positive benefit in a meta-analysis with these agents. Other meta-analyses showed a relative risk of 55.55 for tamoxifen, which represents a 45% reduction, and a relative risk of 0.43 or a 57% reduction for raloxifene. So the data are convincing from large numbers, thousands of patients, that these drugs reduce risk. And here's the illustration from Cusick's 2013 update of the meta-analysis. Obviously, these agents have no effect on estrogen receptor negative breast cancer, shown on the right middle, but far right is the benefit in ductal carcinoma in situ, and in the left middle, the estrogen receptor positive invasive breast cancers in this meta-analysis had about a 45% reduction in risk. Now, despite all of that data, and despite FDA approval in the United States of tamoxifen for breast cancer risk reduction, of raloxifene for breast cancer risk reduction, when you track the uptake of either tamoxifen or raloxifene in the US between 1995 and 2008, the period of time during which these trials were reported and received large coverage in the print and video media, there was no uptake, no increased uptake of these drugs, showing that they really were not adopted for breast cancer risk reduction. And several studies have looked at why this may be the case. One reason is that many postmenopausal women use hormone replacement therapy to control menopausal symptoms, and those hormones are contraindicated to be used concurrently with the SERMs. And patients perceive erroneously that the risks of SERM therapy are greater than its benefits. They misunderstand that, for example, they know about the endometrial cancer effect with tamoxifen, but they are unaware that raloxifene has no such risk. I did not show the favorable thromboembolic profiles with raloxifene, which are also 30% lower than with tamoxifen. And there's the perception among patients and perhaps even among physicians that the therapy-related side effects are greater than the risk of breast cancer, which is often not the case in those women, certainly not for those who have globular carcinoma in situ, atypical hyperplasia, or a increased quantitative risk. But we also know that women and even some physicians are confused by the concept of quantitative or probabilistic risk, and that, as we've said several times, that women really fear endometrial cancer out of proportion to its true tamoxifen-related risk. As we said, it's about 2 per 1,000 postmenopausal women per year, or about 1% of all postmenopausal women over a 5-year course of tamoxifen. And women are, as we've said, they're unaware that there's no uterine malignancy associated with raloxifene, and the medication costs very often in the US, insurance very often will not pay for these drugs for reduction of risk, although both drugs are now generic. And there's this perception by both patients and physicians that perhaps while we can estimate the increased risk among groups of women, which we do very accurately, for an individual woman, we don't have yet a means of accurately predicting an individual woman's risk. And there's also this lack of understanding, particularly among clinicians, that these high risk thresholds really maximize benefit and minimize harms. That is, no one would advocate using these drugs in all women, but when you use them in women at increased risk, then the benefits far outweigh any risk. I recently wrote an editorial in Cancer Prevention Research reviewing these physician barriers to prescribing breast cancer chemoprevention agents. And I stated there that physicians are not sufficiently trained in risk-benefit counseling techniques and risk reduction options. This is not something that even many oncologists are not comfortable with, and very few primary care physicians are knowledgeable or comfortable with this approach. In the US particularly, but I'm sure it's true elsewhere, the study I commented on in this editorial that showed these data was from Australia. And they noted that there was insufficient time and lack of reimbursement, and that the number of women you needed to screen to find an eligible woman among the premenopausal women was 26. That is, if you thought a woman might be at increased risk and you screened 26 premenopausal women ages 40 to 49, only one of 26 women would fall into the high risk group. And if you screen women 60 to 70 years of age, you'd actually have to screen 142 women to find someone at increased risk. And then, as we've mentioned several times, there's concern about side effects. And these are often not reported in a way that's understandable. But interestingly, primary care physicians report prescribing raloxifene, probably more for osteoporosis prevention compared to tamoxifen, where only about 10% prescribe the drug, largely based on concern about side effects. Now, in the last several years, a number of groups, the U.S. Preventive Services Task Force, the Canadian Task Force on Preventive Health, the American Society of Clinical Oncology just 2 years ago, and last year, the National Comprehensive Cancer Network, all of these groups recommend that high-risk women should both be identified and then they should be counseled about the benefits and the risks of using SERMs for risk reduction. And all of them use the 1.66% Gale model risk that was used in the prevention trials in the US. That number, 1.66%, is the 5-year risk of a North American Caucasian woman who's 60 years of age. So that's the average risk of the average woman at the average age of diagnosis. I should also mention that the Gale model includes risk estimates for ethnic minority groups such as African Americans and Hispanics. So the model is very useful, and the recommendation uses the Gale model or women who have lobular carcinoma in situ. So who should we consider as subjects that are potential targets or would benefit from the use of SERMs? Well, certainly those with lobular carcinoma in situ, as we showed in the breast cancer prevention trial. Those with ductal carcinoma in situ, I've not shown the data, but there are published randomized trials with both tamoxifen and aromatase inhibitors that show a large benefit in terms of reduction in the incidence of contralateral second primary tumors in women with a diagnosis of ductal carcinoma in situ. And we've talked at length about the benefit in women with atypical hyperplasia. There are also published trials, most of them cohort trials, not randomized, that there is a benefit of breast cancer risk reduction in both BRCA1 and BRCA2 mutation carriers. In our breast cancer prevention trial, we were able to look at the benefit in BRCA2 mutation carriers. Most of these women develop estrogen receptor positive breast cancers, and there was a statistically significant benefit to women with BRCA2 mutations in the reduction of breast cancer incidence when they took tamoxifen. And in our genetic high-risk clinic, only about half, and the literature supports only about half of women with known mutations elect bilateral prophylactic mastectomy. So for those women who want to retain their breasts and do not want to have mastectomy, the consideration of use of the SERMs for risk reduction is a realistic option. There are few data, however, on other mutations, such as PALB2, BRIP1, and other predisposing genetic mutations. And as we've said, women with a Gale model risk factor profile 5-year probability greater than 1.66 or 1.67, that is in the FDA label for both tamoxifen and raloxifene in the US. These drugs should probably be avoided in women who've had thromboembolic events, including stroke, transient ischemic attack, deep vein thrombosis, or pulmonary embolism. These are estrogenic compounds. They are thrombogenic. It is true that raloxifene in the STAR trial showed 30% fewer embolic events, but it is probably wise to avoid giving these drugs to women who've had a history of these events. Tamoxifen has been shown to cause a slight increase in the risk of cataracts. And so that's a discussion that would have to be had carefully with a patient who had a history of cataracts. And as we said, the use of SERMs is contraindicated in women who are taking hormone replacement therapy. So where does that leave us? Well, the American Society of Clinical Oncology recommendations that were updated just a little over a year ago said that in postmenopausal women, we really have 4 choices: 2 aromatase inhibitors, anastrozole and exemestane, the benzothiophene SERM raloxifene, or tamoxifen. And the decision regarding the choice of endocrine therapy obviously should take into consideration age. We believe in our high-risk clinics that even the mutation carriers, as they age, as they get into their early 60s and early 70s, they essentially have, if you will, expended their risk. And so much older middle-aged women are at lower remaining lifetime risk than our younger women. And those considerations should be taken into account when deciding about these drugs. We mentioned baseline comorbidities, particularly thromboembolic events, and a discussion of the adverse effects is certainly warranted before initiating these drugs. You cannot prescribe the aromatase inhibitors or raloxifene in premenopausal women because there are no data, and the aromatase inhibitors would not be effective in those women. And tamoxifen for 20 milligrams a day for 5 years is still considered the standard of care for premenopausal women who are at least 35. There are no data in women younger than 35, but at least 35 years of age and who have completed childbearing. Tamoxifen must be avoided in women who could be pregnant because it does have teratogenic effects in mice. The Preventive Services Task Force last year, 2 years ago, said that women at increased risk should be have discussions with their clinicians about risk-reducing medications, and they should be counseled about both benefits and risk. And this was a grade B recommendation, which is from the task force a fairly high recommendation. And the National Comprehensive Cancer Network, in their most recent update of their breast cancer risk reduction guidelines, which can be found at the website shown here, has recommended that these agents be discussed with appropriate candidates. So there are literally millions of women in the US and across Western Europe and the rest of the world who are at increased risk. The SERMs and the aromatase inhibitors definitely reduce the risk of breast cancer in high-risk women. Their underuse is probably based on misinformation among both the potential subjects and their providers. And as we have just seen, national and international experts recommend the use of these drugs in age-appropriate women at increased risk. And I believe it's now incumbent upon clinicians who see and manage the health issues in all women, that they become proficient in both risk assessment and the counseling of the use of these agents in appropriate high-risk women. So again, I want to thank the meeting organizers for this opportunity, and I'll be happy to answer any questions.
Thank you very much, Professor.